Good afternoon and welcome to Health Choice Network and Alliance Chicago in Action COVID-19 webinar series. We'll be starting our broadcast shortly, but if you want, please participate in our live word cloud. Take out your cell phone and type in 22333, put in COVID-19 heroes, and then let us know what you are looking forward to in the year 2021. Looks like national travel might be coming up.
Hello.
Hello, the webinar will be starting shortly. Health Choice Network and Alliance Chicago in Action. Today's webinar will be starting shortly, but first, we want to make sure that everyone knows we are forever grateful for our healthcare heroes. Before the webinar starts, join us in our live word cloud. Type in 22333 on your phone and put in COVID-19 heroes in the text line. And then the question is, what are you looking forward to in the year 2021? Let's think positive. Let's look ahead. The webinar will be starting shortly. Alliance Chicago and Health Choice Network, better together. Webinar is going to be starting shortly. Look at this QR code. You might want to register. More information shortly. The webinar is going to be starting in a couple minutes. Health Choice Network and Alliance Chicago are forever grateful for our community healthcare heroes, proudly standing behind our health centers. The webinar will be starting shortly. Join us in our live word cloud. Get out your cell phone, type in 22333 and put in COVID-19 heroes into the message line. And then join us for our question of the day. What are you looking forward to in the year 2021? A lot of things going on here. Alliance Chicago and Health Choice Network. The webinar will be starting shortly. But first, innovating now for tomorrow. Better together. More to come in just a few minutes. Health Choice Network and Alliance Chicago in Action. Our COVID-19 series, COVID testing and mitigating the flu. The webinar will be starting in just one moment. Join us for our live word cloud today. Get out your cell phone and put in 22333 and then type in COVID-19 heroes. Join us for our interactive question. What are you looking forward to in the year 2021? The webinar is going to start in just a moment. So as we start today's webinar of our COVID-19 series, COVID testing and mitigating the flu, please join us in our word cloud. Get out your cell phone, type in 22333, put in COVID-19 heroes in the message line. You'll get a response back, and then you can join us in our interactive question. What are you looking forward to in the year 2021? Hopefully a lot of good things in the upcoming year. Concerts, outdoor sports, good health, international travel. Maybe someone's getting married, vacation, seeing family, concerts, Miami Heat games, house parties. There's a lot going on, and there's a lot to look forward to. So as we start today's webinar, Health Choice Network and Alliance Chicago in Action. Today's webinar is on COVID testing and mitigating the flu season. This is our 12th in a series of COVID webinars since the start of the pandemic. We're thankful that you have joined us through all of these sessions. And today, we're going to hear from our partners again at Quest Diagnostics. Then we'll hear from the Chicanis, which are the Community Healthcare Association of New York. We'll hear from a couple of health centers. Providence Community Health Center will be first, and then we're going to hear from Family Health Network of Central New York. And finally, we're going to hear from both of our CEOs, both Alex and Fred are going to let us know what's coming next. So why don't we turn it over to our first speaker, Dr. J. Oh, I'm sorry, my team is a little ahead of me. Sorry, Dr. J, 1 second. First, we're going to do an interactive poll. So hopefully you can participate in our poll question. So the poll question number 1 is, how is your health center ensuring your staff get the flu shot? A, mandated. B, strongly recommended. C, encourage it. So Stephanie, why don't we open this poll, and we're going to give it a couple of minutes to be able to complete the poll. How is your health center ensuring your staff gets the flu shot? Mandated, strongly recommended, encourage it. So why don't we give it just a couple more moments, and we have people live voting, and we'll see what the response is. And let's give it 5, 4, 3, 2, 1. Stephanie, why don't you show us what the results of our first poll question? And here we go. 35% of health centers are going to mandate the flu shot. 60% are going to strongly recommend it, and 6% are going to encourage it. Great results. Thank you very much. And now, Dr. J. Dr. J, we'll let you introduce yourself. You have spoken before this audience before. We thank you. So we'll turn it over to you to hear about COVID testing innovation. Jay?
Got it. Thank you. And thanks for using a picture for me from a couple decades ago as well. That's very kind. But I'm happy to be back here and just would like to give about a 15-minute update on what we're seeing, what we're working on, what's going on relative to COVID and flu. And so next page, please. So, this is our year-long journey, and it is now September and almost October. So this will be a year-long journey for all of us and into 2021. It all began, of course, with making testing available, PCR testing in particular, and then scaling that up and getting through some tough times relative to capacity for PCR testing relative to overall demand in the country, which was occurring through the summer. Since that time that we made testing available, we now have testing in 20 different laboratories across the country. We can process over 220,000 PCR tests a day. But also, it wasn't just about the testing capacity. I think a big part of this is how are we getting the tests done? How are we getting the swabs collected in the community? And so along the way, we received a EUA for a anterior nares self-collection kit for SARS-CoV-2 PCR. And that can be, of course, shipped to an individual address or distributed out of a clinic, and people can safely swab at home, send it back in at room temperature. I mention that in particular because as we get into flu, I'll mention where we're going there. And of course, we would like to have a capability of doing flu COVID combination testing, but also have it available in a self-collected swab kit as well. And then most recently, really to get to the capacity that is needed, we had to start pooling. We were granted the first EUA for that on July 18th. And that's made a huge difference just at Quest, but also in the whole industry, and being able to meet the demands of the reopenings and also the ongoing testing, PCR testing that's out there. Next page, please. So I'd mentioned, of course, the self-collection PCR, and it is, just as a reminder, it's an anterior nares swab, which I have here, and it is in the front of the nose. It is not a mid-turbinate or a nasopharyngeal swab. That was actually what the FDA wanted us to do after looking at all the data. And it's here that we will be adding in influenza A and B as an option. So what I would say is right now there are testing solutions available out of Quest and other labs that allow a combination flu COVID test. In addition to that, though, I'd like to get it available in the self-collection kit, and we're working over the next few weeks to make that happen. We also, have looked very hard at the saliva sample type, and have seen data that suggests that it is a less sensitive sample type with a higher limit of detection than a nasal swab for PCR. However, after a lot of work with the Yale group, and also just keep in mind the Yale team was working with the NBA, where they had concurrent swabs and saliva in a very large cohort. So through that, it does appear that, saliva can be a good sample type for collection for a PCR, but it is only a new collect sample type. It is not a change on the back end technology, so it really doesn't change the turnaround times. But we're positioning this and making it available for screening and surveillance initially, because we do still see that it has a higher limit of detection than a PCR. And so we do not recommend that saliva be used in a symptomatic patient or for diagnostic purposes. If someone is symptomatic or has had a high-risk exposure, we recommend a nasal collection for PCR. In addition, we've been working very hard for about 3 months on vetting all the rapid antigen tests out there, identifying one in particular that we think has a very good performance, surprisingly good performance. It appears to be very specific, but also its sensitivity is getting close to the level of a PCR test, of some of the PCR tests that are out there. So we are planning to make this available over the coming month. And again, in the screening and surveillance setting. One of the confusing things that has happened in all of this is that as the rapid antigen tests have become available, they've been positioned for and actually approved by the FDA as to be used in symptomatic patients for diagnosis. And I think this was done because the backlogs in the lab industry and concerns that there wasn't enough access to PCR. But if you really look at that, it's not that useful in that setting at all. And the reason being that, in that setting, the FDA says confirm all negatives, meaning you have a symptomatic patient, you're going to test them once. If they're negative, you're going to do a PCR, which is going to be 90% of the time. So we're developing antigen testing and working with the FDA to make it available for a screening population. And so right now, as we're working with large companies and health systems, nursing homes, for example, there's a real strong desire to have more than symptomatic PCR available. And it is problematic to begin to say, well, let's screen with PCR or do surveillance with PCR, although a lot of organizations are doing that today. So we believe that this would be a very nice tool to have available for screening of low-risk populations. And in that setting, it's akin to a temperature monitoring device. Actually, that's the predicate device. It's just a much better mousetrap for that, meaning in that setting, if the person is tested, they're low risk and they're not suspected or they're not symptomatic. If they're negative, they go on into the nursing home to do their job. If they're positive, they would go home and isolate and have a confirmatory PCR. And so that will be coming very soon from Quest, but there will also be, of course, lots of other antigen tests all out there. And what I'm going to say is they're not all created equal at all. And so there's a really significant range in the sensitivity and specificity around the antigen tests, which is why we've vetted, the one that we have. Next page, please. And I think this group understands the difference between antigen and a PCR or nucleic acid testing. And it's really around the sensitivity. These antigen tests will not be, at least in the near term, as sensitive as a PCR result. And of course, PCR has very, very high specificity as well. And so you can see why we believe that the role of the antigen test is in the asymptomatic or screening populations. Next page. The antigen test will provide a result on site within 15 minutes. The longest period can be up to 30 minutes, although we're working through that with the FDA. And again, you would confirm positives. And as we roll this out, it will become available in CLIA waived settings that we work with our customers, an employer, a health system to designate their location as a CLIA waived site. And then ultimately we'll get to a place where that's no longer needed. And that has to do with providing a software program that will literally read the lateral flow kit and then provide that data into a system that will allow us to get to a place where this can be done anywhere. and actually out of a consumer's home as well. Next page. And then, serology, it's, I believe there's going to be an awful lot of resurging interest in serology testing. As of now, the way we use it and recommend that it be used is really just in identifying a case of an individual who has been infected and has recovered from SARS-CoV-2. And by identifying cases, we also are identifying people who are highly unlikely to have a serious reinfection with SARS-CoV-2 this season, and also are highly unlikely to bring the virus into the workplace with them. And so as we're looking at a population level, at a reopening large companies or hospitals, you start to see that, question of, if I'm conducting a screening or surveillance program, do I need to screen everyone? And why would I be spending my screening dollars on a group of people who are not going to bring the virus into the workplace with them? And so in that regard, we've done a lot of work to say, here's how antigen and here's how serology might help in that environment, sort of point the guns in the right direction, right? And say, here's a group of people who may not need to be screened or surveilled. Also, I'll mention that the quantitative serologies are coming. A lot of the IVD manufacturers, they all have a program whereby there will be the next generation of serology, IgG, that will have a stronger linkage in their interpretation to protective immunity. And that's literally happening over the coming weeks, and we'll see how it all plays out, particularly as the vaccine is coming. And I think a big question on everyone's mind is, what would the role of quantitative serology testing or other testing be to prioritize populations or to understand protective immunity after vaccination? So a lot of work still to be done there. Next page. And I'm not going to cover this in detail. I'll say that our group published a paper recently, which was in Population Health Journal. And it essentially is a simple algorithm for how could you think of using antibodies at a population level for a return to work scenario, for example. And some of that work is shown here, and it's just very basic considerations. The main message I want to say is nobody is using antibodies to determine that someone should not go back to work or should. It's more understanding the population and who needs to be screened or surveilled. So that's an important point. Next page. I'm going to skip this. This just says that if you're working with a population and you're trying to use PCR to screen, that you can actually offset the need for PCR by using serology or antigen and save your screening dollars. Next page. So flu, COVID, absolutely needs to be available, although, of course, there are very few cases right now because we shut down global travel maybe at the right time. But in South America, it's very light. Of course, there are travel-related cases coming in now. And then we have available now flu, COVID combo or either one. And then again, we'll try to get that validated in a self-collection kit over the coming month. Next page. I'll skip this as well, just for time. I want to get to, and I'll skip this as well. Yeah, I'll go to the next page. That was just some information on, sort of how we're sort of integrating all the services around school reopenings and employer reopenings. This is an important page, and I want to give you two pieces that I think are pretty relevant to this group. We've been working with our data and also just in a lot of collaborative research around COVID. And you can see on the left sort of the themes that we're working on. And the two I'll point out is, how do we break through to provide services in disadvantaged communities? That's one. And the other one is the seroprevalence work, which is actually really important for people to understand. So go to the next page and I'll explain each quickly. The notion here is the CDC started working with us and other labs over the summer to take our discard samples that are done for other chemistries and then assess an IgG serology in those. And we did it across 8 metro areas and found something that was pretty interesting, which was that by surveying that way with discards, as opposed to using reported data, we end up with a 10-fold higher rate of positivity for IgG in a population. And so what that means is that this helps us understand, maybe at a more of a population unbiased level, what really is the seroprevalence in any one community. And so since this time, we're now doing this in all 50 states, and the CDC is publishing on their website the seroprevalence data by geography. So I think this is a really important resource and something for people to be aware of. And then the next page, I'll just touch on the other area of research, which is, we all know that there is a disproportionate impact on underprivileged and underserved communities, and there are a lot of reasons for that. One of which I believe is just the access to PCR testing or the engagement with PCR testing. And so we believe that the home-based self-collection kits is one way potentially to reach into communities that are not getting appropriate testing. And so therefore we have worked with Centene to initiate a program where we're testing this hypothesis in real time, trying to get after some underserved communities in this way. We intend to publish the results of this, as we do it. And I'd also say for this group, we're very interested in finding other FQHCs or groups that are interested in either a pilot or a local program to try to get at this. In fact, we have a charitable fund that we've created around this based on the pandemic at Quest. So open invitation there to collaborate on that. And then I'll come to the finish here. I know I'm up on time, so next page. The other area of research that we've really gotten into, of course, is just using our data to show what we already know, which is healthcare fell off a cliff this year. And we published a paper that said there's a drop in the rate of cancer diagnosis, but of course the cancers didn't go away. And for example, A1C monitoring in diabetics went down 66% during the sort of the trough. And so therefore, on the next page, you'll see where we're going as a company, and that is to more and more address healthcare needs with home-based self-collection, with retail access points, and then also with just virtual care enablement of everything we do. Physician ordering, telemedicine, consultation on results, referrals into care, and telemedicine services. Now, we provide those through our partners and through our health systems and through our physician offices we work with, the downstream, and also some of the telecare. But big focus for us on just getting healthcare to people in a way that, they can consume in a pandemic when they're locked down, at home. So next page, bring me to the finish, I believe. Last thing, we've learned an awful lot here this year. And so I believe that, over the coming year, we're going to turn this on its head a little bit and say, okay, Quest will always have an assay at the ready for all the respiratory viral threats, which we know of around the world. And then we'll have active surveillance to say it's coming over. And we need to then launch and scale an individualized assay that can be used, ASAP. And if you apply this approach to the current pandemic and go back in revisionist history, we would have saved several months by taking this type of approach. So I just wanted to share that that's kind of, I hate to be doomsday, but this is not our last respiratory viral pandemic. And so I think we collectively have learned an awful lot that will help us out in the future. So that's what I had. And I believe there's questions can be taken online using the chat at some point. So I will hang around and continue to participate.
Great. Thank you very much, Dr. J. We appreciate that. Great information. And that's correct. If individuals do have questions for Dr. J, please type them into the chat and we'll get them to him. So again, thank you very much. And now, as we turn to our next speaker, we're going to hear from a colleague of ours, Dr. Warrior Esmond. And Dr. Esmond is representing the Community Healthcare Association of New York. And so Dr. Esmond, how are you? Dr. Esmond, we might not be able to hear you too clear.
Got it. Okay.
Here we go. What a beautiful voice, loud and clear.
Thank you, sir. So it's my pleasure to give you an update. Several months ago, I had the privilege of speaking to this group about the New York State experience with COVID-19, as we were really the epicenter in this country of this infection that has now gone beyond the walls of New York State and affecting our country in a very significant way. As Tim says, I serve as the Chief Medical Officer of Settlement Health. We're an FQHC in East Harlem, New York. And I also have the privilege of chairing the clinical committee for CHICANES, which is our statewide primary care association that serves about 70 plus health centers across the state. In that role, I've had the privilege of collaborating with my colleagues around the state on what is really a challenging time for us all. I wanted to just kind of begin with a little historical picture of where we were. This graph starts in February of this year and goes through a few days ago. I didn't update it recently, but it shows the impact of COVID-19 across the country, and while not displayed here, obviously across the world. In spite of our extensive efforts, the United States is still experiencing over now 40,000 new cases per day. I checked the data yesterday before I went home. And that's a case rate of about 6.4% positivity. If we look at the graph in early April, and then we'll see in the next slide the graph of New York State accounted for almost 50% of the COVID cases in that time period, again, making us the epicenter. When we look at New York State, we have managed since early June to reduce the incidence of new COVID cases to about 1%. And while that's an amazing feat, we sit here and waiting for the next surge of this infection, especially if we take a look at what's happening in Europe and around the world. Right now, New York State has about a 0.9% positivity rate, which equates to about 700 to 800 new cases per day. Next slide. So what are we doing in New York to date? When we first met, we were meeting weekly as a clinical committee, strategizing and helping each other solve the many issues we faced as health centers in the midst of a pandemic. Since June, we have reduced the frequency of those meetings to every other week. And then you see the list of topics that we tend to cover on those weekly calls. Things like day-to-day operations, how to increase our face-to-face visits while maintaining social distancing so that our organizations can recoup some of the revenue that they're losing every day. How do you safely reopen dental? How do we continue to screen for temperatures at the front door? And the list goes on. Telehealth implementation, as you can imagine, is a continuing dialogue. We've had a mixed success across the state. Some health centers have done very well, whereas others, like my health center, have seen a low uptake with patients who are willing and able to participate in a video visit. We've talked about testing strategies. How many of us are participating in a community screening initiative sponsored by the state, or in our case, New York City? And sponsorship is only in name. There's no financial support for this work. Should we test inside? Should we test outside? And what is the role of rapid COVID testing, which we will get to and we've heard a little bit about already. We've all struggled with our clinical decision making through this pandemic, and our group has continued to support each other in helping to make best choices for our patients and our staff. And while the changes in clinical guidance has settled down as compared to the beginning of the pandemic, we still have experienced challenges with dealing with the nuances of the decisions that we need to make our staff and our health centers stay safe. And of course, we have our staff shortages, which probably should have been at the top of the list. And what we know is that the reopening of schools in New York State, everyone is challenged with maintaining adequate staffing to support their clinical operations. One of the wonderful spin-offs of our clinical committee calls is a subcommittee that was developed to begin a reopening strategy discussion to shared with the larger group. And it's most recently become our bi-weekly support group, where we really hear each other out in our day-to-day challenges. And this becomes the core group of individuals who help drive the agenda for our statewide bi-weekly calls. As I said, many of our health centers in New York State are participating in community testing initiatives that are supported by some test and trace programs. So how are we going to manage influenza-like illness in the fall? We are looking at what are our workflows currently and how might we need to adjust them to account for the changes that we'll see in symptoms presenting at our door. What are the workflows that we need to put in place for sick patients? Some folks have decided that they can take a site that may have been closed due to the pandemic and repurpose it as a sick visit site to keep patients with potential COVID or influenza from coming through the doors of the health center where our healthy patients are. And we do know that patients are hesitant to come into the walls of the health center because of their fear of the infection. We're looking at school reopening and what that's going to do for demand for COVID testing. New York State has a blended model of reopening. Each district was allowed to make its decision. Most schools are offering a combination of on-site learning and remote learning. And as of today, New York City, where I'm located, has delayed its opening of classrooms until October 1, due to concern from staff as well as families. And in upstate New York, where schools have begun their remote face-to-face learning, we're hearing reports of children who are showing up at the health center to be evaluated because they failed the screening at the school. And so what is that demand going to be like when influenza is prevalent in our state? Some of our colleagues have leveraged telehealth to provide assessments for patients. Both new patients and those who are calling with symptoms, they receive a telehealth visit where the determination of their next level of care is made. If the issue can be dealt with via telehealth visit, then that solves that issue. If not, they're scheduled to come in for a face-to-face visit. Some health centers are screening all patients for via telehealth, all new patients via telehealth. And then what is the role of point of care testing, COVID testing, and influenza testing? We heard from our colleague at Quest a little bit about rapid COVID testing, and we're going to talk a little bit about in our next slide what we're doing in New York State. Next slide, please. So as a group of clinical leaders, we are concerned about a resurgence in New York State as well as what's going on around the country. And the biggest challenge is going to be how do we differentiate influenza from COVID because there's such a high crossover of symptomatology. We all agree that monitoring state and regional COVID data prevalence is critical to making operational decisions. It's proposed that when the prevalence reaches 5% in a region, it may be a point that you want to roll back your clinical operations. One piece of good news is that laboratory results are turning around much more rapidly than they had been. If we go back almost 2 months, we may have waited on 2 weeks for a test result to come back, kind of making the purpose of that test futile. Right now, most organizations are getting results between 24 and 72 hours of the test. This improves our ability to identify and isolate known cases. As we've heard, point of care COVID testing is a hot topic for all health centers. We took the opportunity as a group to leverage our primary care associations ability to arrange for group informational sessions for selected rapid COVID test point of care. This allowed for us to take advantage of each other's knowledge and hear questions that you may not have originally thought to ask if you had done an individual demo. So we're currently in the midst of that, and after that, we will hopefully make some decisions. We do know that this is a challenging decision. What test do you select? Do you take an antigen test or a molecular test? As we've heard, an antigen test currently requires a confirmatory for all negatives. We lack good data on sensitivity and specificity. Do you use a single COVID test, or do you do a combined COVID flu? You name it, there are several menus out there that you can select from. And the bigger question is, do you do influenza testing? That's its own debate in a non-COVID situation, and we're having that conversation as well in New York State. Can COVID be used as a screening tool? Can rapid COVID testing be used as a screening tool? And that's one of those additional questions we're trying to get answers to. And to top it all off, New York State is mandating reporting of all COVID results to a statewide database, which at a point of care environment, we have to understand how we're going to accomplish that. And the availability of the rapid testing is still limited in terms of our supply. Telehealth is another area that we're really focusing on post-COVID spike, because we recognize two things. One, telehealth is a new business line that we need to embrace as organizations to be successful and offer our patients options for care. But just in case we have a second wave, we really want to perfect our process with video visits. Currently, telephone visits in New York State are reimbursed by Medicaid, although there's some debate there about the impact on our long-term PPS rate. So we're really trying to move away from telephone visits as rapidly as possible. And finally, PPE, which I'm sure each and every one of us has our own stories about that. Given the challenges of PPE supply across the country, we're all focused on securing enough personal protective equipment as well as other supplies, particularly disinfectants, in advance of a resurgence. Next slide, please. So, where are we today? As we talked about, concerns for testing in our communities, particularly our teachers and our students. In our rapid COVID community testing, we're starting to see more and more teachers presenting for care. We heard a rumor that in New York City, the schools are going to require that 10% of staff be tested at some point, staff and children be tested randomly at some point. The mechanism for that is not clear, and we're looking at how we might partner in different communities with our local school districts to at least manage that potential demand and surge. And last but not least, and probably the most concern for us all, is our workforce challenges. Given the concerns for our children going back to school and our staff being of our communities, they too are struggling to meet the educational demands of their children or to have adequate access to childcare that would enable them to come to work every day. Without these critical staff members in our health centers, our MAs, our nurses, our front desk staff, we will be challenged to continue to meet the needs of our communities. We will continue to address our issues in our community. You'll hear a little bit about our work from one of our health centers a little bit later, and I look forward to hearing what's going on in Florida and around the country. Thank you.
Great, thank you, Warria. We really appreciate it for all the work that you're doing in New York City and New York State. So thank you very much.
Thanks.
So right before we get to our next speaker, Dr. Saul, we're gonna have one more poll question. So please take out your eyes here and look at the poll on the screen here. Poll question number 2: is your health center interested in recruiting patients for COVID vaccine trials? And so A is yes, B is not currently, C is need more details. So Stephanie, why don't we open the poll? And now anyone who is looking on the screen, hopefully you can choose your selection to the question of, is your health center interested in recruiting patients for COVID vaccine trials? Either yes, not currently, or need more details. So let's give it a couple more seconds before we close the poll of, is your health center interested in recruiting patients for COVID vaccine trials? Yes, not currently, and need more details. So Stephanie, why don't we go ahead and take a look at those results? And here we go. It looks like 8% are yes, interested in recruiting patients. Not currently is 50%, and 43% need more details. So there's a lot of work and interest going on in COVID vaccine trials across the country. Certainly want to make sure that our patients, our minority patients that we serve in our health centers, are included in those trials. So more to come on a future webinar for that. And now I want to turn it over to a good colleague of mine, Andy Stahl, and he's going to let us know about what's going on at his community. So Andy, take it away.
Well, thank you all. Is the audio working before I start lamenting my life?
Perfectly.
Oh, good. Because I was about to say, every time I feel bad for myself, I remind myself of my colleagues immediately north and south of Providence. They are Boston and New York City. And we hopes and prayers go with you guys, man. It's been tough up here in the Northeast, but every time I feel bad, I just think of everyone in New York and hang in there. So my role today, kind of bookended between the two New York City health centers, is we're going to talk about practical things you can do to get ahead of influenza vaccine. And for those who know me across the country, we've been having fun with this. We deployed a lot of these strategies for H1N1, and now more than ever, here are about 12 things you need to know if you intend to vaccinate more than a few dozen people. And we're geared up right now to go for 30,000 in the next 90 days. Next slide, please. So of course, Providence is connected by high-speed rail to both Boston and New York. And when the pandemic broke, we got punched in the jaw. Next slide. There we go. And whenever you deal with a pandemic, that of course is our holy candle to St. Anthony of Fauci. Prayer is important, of course, but so is an effective public health strategy. Next slide. And so we wanted to do this the fun way. Of course, we look upon emergency preparedness as why stop? In fact, our annual influenza vaccine is our standing drill for our emergency preparedness team. So never settle for a tabletop activity when you've got this great project you can work on every year. And of course, practice makes perfect, especially when you were probably planning to vaccinate 30, 40, 50,000 people in the next months anyhow. So of course, the basics of public health. Rule number one is don't accidentally create a barrier to care, and be humble and willing to recognize that your own system may be a barrier to care. Public health rule number two, it's always the system. It's the system, it's the system. Look at your systems, don't blame people for this. And of course, number three of all things we do in primary care, if you delay a vaccine, you've denied a vaccine. So here are those dozen things I mentioned that you may have overlooked when you were planning your campaign. Next slide. So remember from the start, you need your entire senior leadership behind you on this project. Sure, the docs and nurses get it. Do they really? And do they talk to each other? Be aware that just because people have a medical diploma or a nursing diploma doesn't mean they really have a clue. We as physicians, nurse leaders, and others have to work on communication across the silos all the time. But don't forget the rest of the people on your senior leadership team. I have worked with CFOs who looked upon flu vaccines as a revenue-generating opportunity. That's good, and it's not good. Have you spoken to your CEO? Are they looking at this as a must break even, or do they see beyond, and are they willing to look at a lost leader to get you some intangible goals? Of course, do your operations people think it's business as usual? Well, historically, we've always brought people in to vaccinate them. Therefore, that may not work this year. And of course, if you are going to be doing outside work in tents or in alternative sites, has your IT department been brought into the loop? Because wireless is really, really hard technology. And of course, don't forget your outreach people. What were you planning to do? And of course, as you go around and you sell this and you want everyone on board, the book is called Start With Why. I love this book. Give people the reason why they want to be part of this project. Of course, the easy answers, flu vaccines are public health 101. For those people who work in HR, my goodness, you're going to keep your workforce happy and healthy and safe. If you got somebody who does a total cost of care or a population health contracting, risk managers love to hear reduced total cost of care. Other people need to know it's a customer service goldmine. Happy patients, new patients. If you do this well and do it right, you're going to have people beating a path to your door. You can be the health center of choice. And of course, anybody who's involved with fundraising will recognize the goldmine that this represents. I'll come back to this later when we talk about opportunities to fundraising. And of course, the strategic-minded people, you know why we're really talking about flu shot even today at this on this conference. We are laying the groundwork for our COVID vaccine campaign for early next year if things go well. And of course, my favorite thing of all is staff morale. We're going to close with this at the end, but realistically, you have to realize just how frustrated people are. But a flu vaccine campaign is something they can do. So a quick rule here, when you're working with your favorite CFO, you have to persuade them to think beyond the billable. And you, of course, need to make certain you understand how the billing happens. So clarify this in the summer, or go learn it now if you don't. Know your payers, look for those hidden co-pays, even if they are inadvertent. Know your billing codes. How does it happen? How do you bill it during a regular visit? How is it billed as a nurse visit instead, or completely independent of a visit? And my big argument I have always made with people is you want to make these flu shots at no cost, because even $1 can be a barrier to care. Now, how I've always worked with CFOs on this, it's a quite simple argument. The amount of time you're going to spend figuring out who the patient's payer is, and if it's at a $1 copay or a 10 or a 0, you know what? If you just say they're all at no cost, you're going to come out ahead in the end, and I can show you the math on this. So the phrase we like to say, of course, is no charge for all insurances and no charge for the uninsured. And if you can get your CFO on board at that, it's much easier for the marketing. And of course, CEOs, they see the world through their own eyes. At no cost vaccine may sound like a loss leader in the short term, but it has mammoth direct and indirect payoffs for the health center. Public relations and fundraising being the foremost piece of that. But don't forget, you can get new patients into your health center. You can reduce the total number of hospitalizations and the total cost of care, keep the employees healthy, reduce absences, and of course, prevent transmission in your clinic. CEOs generally like to hear that. Back to that fiscal argument, hey, $5 is a barrier to care. Even $1 can be a barrier to care. So I challenge you to work with your teams, try and see if you can just waive those co-pays. If United and Blue Cross and Aetna can come forward and say, you know what, we're going to do it at no copay, your health center might want to consider doing that as well, particularly for the sliding scale patients. Try and get around that nominal fee or write something into your policies to circumvent that. And of course, I had one CFO want a guarantee they wouldn't bleed out. And so I said, look, we're talking about $5,000. And we put the word out that we wanted a donor to help us get something done so that, you know, could we handle the uninsured? And you better believe we found somebody very quickly who wanted to do that. And the other down and dirty, you've been in the federal system too long strategy is take a look at your last COVID grant, wherever you got it from. And look at how it's being drawn down. If it was about testing or treatment, or was it about clinic support? Our argument has always been influenza is the vector that's going to drive that second wave. And if that can't get your project officer on board with paying for that little bit amount, this will. You say, we're building the infrastructure to deliver that COVID vaccine next spring, and this is our test pilot project. Of course, speak with your project officer. I'm not a lawyer. But so far, they kind of look at us and they've said things like, well, if you think it's going to work, great. So we go from there. Next little rule here. Have you checked in with your favorite RN lately? These are the people who know the vaccine refrigerators, the alarms, procurement, who can vaccinate, what kind of training those people have had, and more importantly, they understand the documentation, the lot numbers, and the digital trail. I challenge all of our colleagues who are physicians and others, listen and learn. And when you see the world through the front line of the immunizing team, look for potential barriers in the system. These can impede vaccine delivery. And hopefully, if you take apart your system and look at it, you can recognize these things and work to get around them to begin with, help them to succeed. Of course, my favorite barrier to care is me. I'm a physician. I use an EHR. And if you're waiting for me to click the button on the mouse in order to order a vaccine, then I myself have become the barrier to care. Please take a look at your standing orders, particularly around preventative services and, more importantly, immunizations. You know, if you know you want to do it anyhow, don't wait for me to make the order in the EHR. Next slide. And one of my favorite standing orders of all time goes like this. If the patient is due for a flu vaccine, give them one. And our vaccines often look at who else is present in the clinic. Is it the partner? Is it the parent? Is it the sibling? We want the nurse or the medical assistant to proactively say, hey, who else is here? Are they patients? Can we quick reg them? Let's get them vaccinated, because you never want to miss an opportunity to vaccinate. Next slide. And of course, our medical assistants are a crucial part of this when patients are in the clinic. We do script messages and we have them delivered. There's 2 on the screen here. Do you want a flu vaccine today? That's an opt-in strategy, and that's going to plateau at about 40% of people saying, sure, I'll get one. But if you make it an opt-out strategy, you get something radically different. And this, of course, is what my nurse says, because I'm always running behind. They go in the room and say, Dr. Saul wants to apologize, he's running a little behind, but he wanted you to get the flu vaccine while you're waiting. And suddenly you get up near 80% acceptance rate. So that's a standing order coupled with messaging. So maximize your team's impact. And of course, our secret sauce here is we incentivize care teams. We incentivize them for preventative services, A1C rates, blood control rates, and of course, adult and pediatric immunization rates. Next slide. So another piece of this is, if you haven't called your main phone number lately, I challenge you to do this. Try to be a new patient, try to access your system. And imagine if you were new to town and all you wanted was a flu shot. Warning, this can be humbling. Remember that your phone system and entering your clinic is often one of the greatest barriers patients will face. So take an objective look at that and see if you've got a fast pass or an access or a gold card method for people to get in. And then, of course, look at your system. Do you mean you have to have an appointment to get a flu shot? An appointment with a clinician, or an appointment with a nurse, or an appointment with someone else? This is COVID time. You got to be careful how you phrase this. Do you need a visit that day? Or better yet, what minimum data do you need to create a new chart? And this is called quick registration, depending on your EHR. And yes, the FTCA does cover this. You call it a health fair, and there are ways to get around your own system at fast tracking people in, minimum registration, and of course, vaccinating them. Let's take a look at the docs real quick. It's a moment of re-education that you too can be involved with. Historically, we always memorize lists of who needed vaccines. Unfortunately, when you teach it that way, if all you do is memorize who needs the vaccine, the subconscious assumption is, well, everyone else does not need a vaccine. And if you've looked at the data lately, if you sit there waffling, you're going to miss the opportunity. Next slide. So, of course, this is how we teach it. Who needs a flu vaccine? Everyone, period. Everyone needs a flu vaccine. There's actually one exception there, and it's, darn near died from shock or Guillain-Barré is the big one. And of course, egg allergy, everyone's running around about egg allergies. Have you seen the data lately? And when you look at it, CDC even now says there's no safer place to risk it than in a clinician's office. So that's our messaging downstream to everybody in our organization. Even with egg allergy, we're going to do the shot, but you got to sit here and we'll watch you for a few minutes. Of course, don't forget to get your outreach people involved. Have you seen your website lately? Are they doing any outreach through Facebook? Do you have texting options? We're working on that. Of course, our Spanish-speaking liaisons are on the air, and we are actively targeting high-risk segments of our population with texting, trying to get them to come in now. Next slide. And next slide. The next slide, there we go. So of course, here is the problem of COVID. As always, we have historically done a good job of taking care of people who come into the clinic, but if you really want a public health strategy, you need to escape the confines of your clinic. Next slide. And of course, thinking outside the box, meet the box. Next slide. Your physical building is part of the problem. And of course, historically, we've been very, very good at taking care of people who show up in our clinics. The challenge of population health and accountable care organizations is, how do you take care of the people who are missing? Who's missing? And is my clinic part of the problem? Next slide. And of course, business as usual, think about what's going on in COVID. You can't get into the clinic. Of course not. It's by appointment only. We're screening you once or twice at the door. And if there's anything suspicious, we're going to defer you to a telephone visit. Well, that flies in the face of an immunization strategy, because you're facing the idea that every time you miss an opportunity, there's a good chance they won't be vaccinated. Next slide. So I always look at this as a problem of, why aren't my patients coming? Are they unable? It's not that they're unwilling. Are they unable to access the system? Are they unable to access the facilities? Are they unable to access us during our hours of operations? So realistically, as you develop your own public immunization campaign, you have to ask yourself, what's our plan for people who can't show up during regular hours of operation? Not everyone can keep banker's hours. And come to the humble realization that despite our best of intentions, these pandemic secure clinics that we've built are becoming barriers to care to deliver immunizations. Next slide. So of course, we need to take a fresh look at a building. Next slide. So here's some of the things we're trying. In this picture, I've cut off the main clinic, which is to the right and off the slide. But we've identified several of our older buildings that have fire escapes, that have emergency exits. And suddenly you too can arrange a one-way carousel to bring people in and out of your clinic through a back door, but more importantly, avoiding the population centers. Next slide. So what we've done is we're trying to get a lot of our high volume immunization pieces and procedures away from the waiting room and away from where the patients are. In this particular model, we sacrificed a back hallway of one clinic. We're also doing this in evening hours, morning hours, and on Saturdays. As always, remember to allow adequate time to clean up your facilities and let your air handlers purge the air if you're doing this. But again, think way outside the box, because as I mentioned before, our problem is we're screening people before they can even enter your building. If that's true, then don't be in the building. Of course, this is an idea. Hey, look at the parking lot operations we've already set up for COVID. Get your teams outside. And just as a caveat, notice no one's wearing a mask. That's right, this is clip art. I cheated. I didn't have a photo when I put this together. So move your immunization campaigns out to your parking lot. Next slide. And don't forget, FTCA does cover health fairs, storefronts, church halls, supermarket entrances, anything goes, so long as it's ventilated, please. And of course, masks not optional. As public health advocates, you should say that. And of course, don't just be way outside the box when you can be way, way outside the box. Here's something we're trying right now. You know that COVID test site you had set up? Ours, you can walk through, you can drive through, but we had these off hours. We were meeting our capacity in the morning hours. So now we're looking at afternoons. Next slide. And of course, and the next slide after this one, there we go, is our standing orders that just were deployed for the drive-up immunization flu clinic. If you haven't run the math on this already, I bet your COVID testing teams would love to do something a little different. So this isn't the full-on PPE, but it is pretty good PPE. And if you look closely here, we're doing only children 6 and up. If you're talking about a 6-month-old, you know what, we want to do that in a very, very controlled setting with the child on mom's lap. And notice we also excluded egg allergy from this setting. If you're going to have an egg allergy and we're going to immunize you, we want to make certain that it's in a clinic or at least in a controlled setting. Next slide. And I want to leave you with this. We were worried about staffing, but our staff is willing to work overtime for flu shots. And we've even got 2 nursing schools calling saying, hey, can we come and help? Next slide. And this, of course, is the best final thought I can give you, is that your staff has been waiting for this opportunity. They really do want to make a difference. And the quote there is from a nurse at our facility last week. And she said, I need to do this because I can do this. They felt powerless for 6 months. They want to kick this thing's butt. And there's no better way than by starting with the immunization campaign. Because if you can knock down if you can knock down influenza, you can help mitigate or alleviate that second wave that we are fairly certain is coming. Next slide. So this is how you find me if you have any questions. And Tim, if there's one or two left, there's a few more images of the guerrilla campaign we're using for employee health here in the house. Of course, we like to use a little bit of humor. Get a clue, not the flu. Of course, we do this for all of our employees. The next one, pretty straightforward, stomping out COVID, of course. And my favorite one, my 16-year-old daughter designed for me, is the next one. There we go. Another sign that fall's arrived. There is nothing tasty about pumpkin spice Twinkies. And of course, there's nothing tasty about influenza either. So please remember to get your flu shots. And I'll stop talking and turn it back to you, Tim.
Dr. Saul, thank you so very much. I love not only the presentation, but the presentation style, and the slides are fantastic. And I just want to let everyone know there's all kinds of transitions in here, so it's much more fun when he's doing it in person. And that will happen hopefully in the future. So again, Andy, thank you so much for presenting today. So next, we're going to hear from another one of our partners in New York, Family Health Network of Central New York, and Dr. Doug Rauner. Doug, are you with us?
I am with you, yes.
Hello.
Hi. I think I'm just audio, is that correct?
You can, but if you want to turn your camera on, that's great. But otherwise, we're honored just to hear your voice.
Not sure where, share my webcam. Oh, I can do that. I will appear. Hello, everyone. Just to show you, I have my own Dr. Fauci candle. He is a saint, after all. I am from Family Health Network of Central New York. We are upstate. We're rural in New York State. I am Warren Esmond's country cousin. Yes, we are related. And I want to talk to you about our journey through the whole testing and mitigation, mostly for COVID, but now we're looking at flu vaccine and flu mitigation as well. When the pandemic hit, it really hit New York City very hard. Our part of New York State really never really got the brunt of it, and we continue to have really low positive test rates as well as cases per 100,000. So our risk never became all that significant. However, we went and did what we needed to do on March 23rd. We began our drive-through for COVID-19 testing and have continued to do that up until this point. At some point during the summer, when our demand went down for that, we went to doing it 3 days a week. Along the way, we began to prepare for the fall, and one of the things that we wanted to do is make sure we had adequate supplies of flu vaccine, and we normally order that well in advance, and so we decided to order 50% more of the vaccine this year, hoping to have enough for what we thought was going to be a very concerted effort. As we're dealing with the pandemic and the testing, we, like many other organizations, had issues with turnaround times. We actually tried 3 different lab vendors trying to get the best turnaround time, and happily we are now in a good place, which Worry had mentioned. We're getting about a 48-hour turnaround time, which for most patients is adequate. But something has happened along the way, and that is school reopening. New York State has had various school reopenings. In the rural parts of the state, most of the schools have opened at least somewhat in person, some totally in person. The state health department has issued guidance for the schools, and if any student is in the school and they exhibit any COVID symptoms, they are to be sent home. And for reentry back into school, they at minimum need an evaluation by a provider as well as a negative COVID test. And so once schools started opening about 2 weeks ago, we, within a very short period of time, just got slammed with every child who came in with a runny nose because they have seasonal rhinitis and it's ragweed season, or every other COVID symptom, which there are many. And so we have been seeing a great many school-age children needing COVID testing. This has been very disruptive for families because now all of a sudden families have to be home with their children because their children are not in school. This has really stretched our ability to see these kids. Our one drive-through has become overloaded with patients so far, and so we just opened a second drive-through today at our pediatric office. We also just today instituted a standing order policy for COVID-19 testing, the SARS-CoV-2 PCR testing for school-age children, to try and get the provider out of the loop as much as possible. I really appreciate Dr. Saul's thought about providers being the slow part of the whole equation here. Right now, what we're also looking at is point of care testing, and I'm actually part of the Chicane's reopening work group. And after some evaluation, we've decided to go ahead and obtain a point of care testing. We went with the Abbott ID Now, which is a molecular test. We have one of these analyzers in our facility right now, and we're waiting for more to come. We're still waiting for the kits that are required for doing the actual testing, and we've been told that we should probably see that in a couple of weeks. This provides a good sensitivity and specificity, and you get results in 15 minutes. So we're looking at a workflow, particularly for our school-age children, that they would come in, particularly at our pediatric office, have testing outside through a modified drive-through testing environment, run the test. If it's negative, then if they need to be seen for some sort of evaluation, we can accomplish that either through a telehealth, or if desired by the parents, we can see them in person. But this way, we are ensuring that we're not bringing any COVID into our buildings, and also we are helping our workflow within our buildings. We are also looking at having flu immunization clinics. In the past, we've had them indoors, and again, we're thinking outside of the box, and we plan on having Saturday drive-through flu clinics. So we're used to doing drive-throughs now, and so instead of testing for COVID, we'll be doing the flu immunizations within the drive-throughs. So hopefully between the increased flu vaccinations that we'll be doing and the ability to do rapid testing, we can get better throughput in terms of keeping kids in school, which is a big deal for us right now, and mitigate issues as we move on. We haven't even hit flu season yet. We foresee that we'll probably be doing a combination of flu and COVID-19 testing with our point of care analyzer. It's able to do both. The advantage that we found with the Abbott is that unlike the lateral flow tests that we had seen before, the sensitivity for the flu version of the point of care testing is in the upper 90s. So we feel pretty good that we can make better and more informed diagnoses and manage people and decide, are they candidates for Tamiflu before they go out and infect people. So that is our journey in a nutshell, just real fast. And I think we're probably running a little late on the presentation, so I will be quiet.
Great, thank you, Doug. We so appreciate you and all the work you're doing, and again for presenting today. So thank you very much.
Thank you.
So next, as we advance the slides, we're going to hear from both Alex Ramillo and Fred Rockman, the CEO of Health Choice Network and the CEO of Alliance Chicago. So as we wait for Fred's live picture to come up, and there we see. Good afternoon, Alex, and good afternoon, Fred. Welcome. Take it away.
Thank you, Dr. Long. Hey, Fred. Uh-oh. Fred's on mute. Here we go. Oh, Fred. It's day 183, Fred. Get off mute.
While we try to mute Fred, we will, just one moment.
Well, Fred finds out how to get off mute, everyone. Thank you so much for all our panelists and our speakers. We are so proud of us, of our teams for putting on this webinar series. I can't even believe we're at webinar series 12, but it's been a great journey. Thanks to all the health center participants, our national partners, our grantees, our vendors. It's been, we've had to do it together, and we need a lot of unity during these times. So we do thank all our speakers, specifically all the medical directors and the clinical staff that are our healthcare heroes that have taken the time to not only share their experiences, but best practices. So, Fred, can we hear you now? Next slide. Uh-oh. Well, as Fred joins us in a second, we are happy to announce the follow-up to our webinar series. The Alliance Chicago and Health Choice Network have been working together for over 20 years. And since it is 2020, we thought, what more first do we need? We always hold an annual conference. The Alliance Chicago does a fantastic job of putting their annual conference together. It's well participated, and we love to go at Health Choice Network, and vice versa. We put on our annual conference held by our board of directors, invite all our health centers, our colleagues, our friends at HRSA and NAC, and make sure that we can educate ourselves. So we this year decided, Fred and I decided that since it is 2020, let's try something new. We are going to be doing a joint educational conference that's now scheduled November 4th through the 12th, and it will be virtually. Next slide. And you'll hear more about that, but the big theme for us is better together. We have to recognize that many of us are much better off together, working together, sharing best practices, and working in groups. And so the Alliance Chicago and HCN have been doing this for over a year, so we're excited about that. So yeah, it is our first joint conference. It is our first virtual conference, and I know we're doing this primarily because we had the option of not doing the conference at all, but we felt that this was our way of giving back to our healthcare heroes and all the safety net providers. So one of the things that we're able to do is work with our partners across both networks and our amazing sponsors, and it'll be the first time that there will be no cost. There'll be no hotel cost, no registration cost, no speaker costs. So we are opening it up to every health center, every 501c3 provider in the community, free clinics, not-for-profit clinics, et cetera. So it's our way of thanking our heroes for working alongside ourselves. Fred, can we hear you now?
I don't know, can you?
Success.
So Alex, I think we maybe wanted to turn it back to you at this point in your transition, but you know, we put together a conference agenda that really looked at aiming to collectively innovate, educate, something that we do together, and also together to accelerate. So keep going, Alex.
Next slide. So as we looked about innovation, we want to look at the boundaries of technology, not just the technology we have today, but the future. We also want to look at all the data resources. I mean, data has played a key role, as the speakers have already presented, and we have a lot of resources across the Alliance Chicago and Health Choice Network infrastructure. But we also want to look inside the organization's infrastructure at the health center and make sure that we're not only prepared, but that the investments that Health Choice Network and the Alliance Chicago Board of Directors are driving at our organizations are actually aligned with the investments you need, not only to deal with the pandemic, but also the after effects, and then 2021 and beyond. So we're excited to be able to innovate together. Next slide. As Fred always reminds us, education is critical. We obviously are looking for every expert in the field. I think you'll be very pleased with some of the national speakers that we'll be able to put together during our annual conference. And that's because of our funders and partners. So we want to learn from everyone, both our health center heroes on the field, but also from the subject matter experts across the organizations that are providing us not only promising practices, but how do we take those promising practices into the near future? Next slide. And lastly, acceleration. You've heard already about how fast we had to brush off our telehealth pilot sites, how fast we had to innovate with our technology, how fast we had to push our vendors. Well, there's a couple of very exciting announcements that the Alliance Chicago and Health Choice Network Board of Directors have done as far as investment goes. And so we're excited that during our conference, both Fred and I will be able to make those announcements that we think will be shape the future of not only our health centers, but make sure it gives them a competitive advantage. We're seeing the rapid change in the environment bring on some new competition and also accelerate some of the competitors we already had in the marketplace. So we want to make sure our health centers are not only strong and survive, but we really want them to thrive because they truly are the front line of defense in our healthcare environment. So Fred, I'm going to pass this on to you.
Okay, hopefully you can still hear. So we've lined up a great series of speakers. So in addition to all the wisdom that will continue to come from all of you as it has on these calls, we've invited some real thought leaders and really TED-level speakers in to speak with us. Amy Herman, who will be very inspiring in terms of looking at perception and how it colors everything we do. Anish Chopra, former health information technology lead under President Obama. Eric Langsher, a noted TED speaker on healthcare innovation. Dr. Kamra Phyllis-Jones, who is a really expert in the field on the impact of racism and discrimination on health. Our own Sue Menair, sharing with us vision from HRSA, and Paul Hushlet, who will share with us and end the conference really with a note on humor. And in case anyone is not aware, humor has a medical impact on health. Next slide, please. So we'll have 14 joint plenary sessions. Here they are, and to the left on this slide, you see a QR code. We'll make sure we're sharing that with the conference materials. And as Alex said, if you scan that code, we lowered all barriers to attending the conference this year. The range of content should really be of benefit and relevance to everyone. This is an opportunity, you all. We really want to reward our staff. So this is an opportunity for people at your health center who don't normally get to attend conferences to have the benefit of doing this. So we really hope you'll share this broadly. Next slide, please. So in addition to those joint big sessions, there are typically, as those of you who have attended our conferences in the past are aware, we'll have breakout sessions. These are largely peer-led, so some of the same quality and content of what you've experienced in our webinars. And then we will have engagement opportunities. We will have a virtual exhibitor hall where you can interact singly or in groups with some of the vendors and other innovators. And we'll also have a gallery of success where we're thrilled that a lot of you have submitted posters to share some of your work. Next slide, please. You probably noticed at the bottom of that slide some fun events too, a virtual mixology and a magic show. So listen, we know this is a super busy time. We know everyone is fatigued from Zoom meetings and video meetings. We've worked with a professional conference presentation firm to make sure that the experience is high quality. And in addition to that, the virtual format really lends itself so that you can customize your experience. You can do as much or as little as you want to do. A combination of live and pre-recorded content. A good deal of the live presentations will also be recorded, so you can view a lot of this on your own schedule, or when you can, we'll leave it up past the conference dates. There are a few presentations by big name speakers where we were prohibited from recorded and those will be live only, so we'll highlight for you which those are. Next slide, please. So with that, we just want to really highlight the process for registration. Alex?
Yeah, Fred, thank you. Well, we're excited about the options. I know as Fred mentioned, I'm all webinared out and video called out, so it's nice that you can customize your attendance. You can also invite all your staff. Some of the barriers in the past for any conference is paying for travel registration. Well, we hope that we can provide this to you and really thank you for being our healthcare heroes. And as Fred has always mentioned us, make sure you get your flu shot, and hopefully we'll see you virtually in November. So thank you very much for joining our webinar series, and we think this will be a great highlight to end the webinar series and move into the next round of education. So Fred, good to see you. Thank you, my friend, and thank all the speakers for today.
And thanks for taking me off mute, Alex.
Great job, and thank you. That concludes today's webinar, COVID-19 and mitigating the flu. Please sign up, get the QR code, and make sure you join us for Alliance Chicago and Health Choice Networks Better Together, Innovating Now for Tomorrow in the fall. Please sign up, scanning the QR code from here, and we're going to conclude today's webinar, but we'll leave this up. Have a great day, everybody. Bye.